Good afternoon, and thank you so much for our guest today. Just briefly going over the staff report, that this is an update on the Minority Health Initiative programs. We will discuss the Minority Health Initiatives next month during budget, when the budget is released on March 13th, 15th, whatever date. So the report just highlights the work of the three initiatives: the African American Health Program, the Latino Health Initiative, and the Asian American Health Initiative. I just want to note that the initiatives have been in place for 20 plus years, responding to the needs in the community. When we think about things that have had occurred, like during COVID-19, the Affordable Care Act, and supporting our immigrant community, that the health initiatives and programs have really been on the forefront of trying to support community members. I know our department has a robust presentation, so I will let them get started, and I can address any questions. Thank you.
All right, thank you for the opportunity to be here. Good afternoon. So I'm here to brief you today on what we have collectively called the Minority Health Initiatives and Programs, but I will say I do not love that name in the grouping. We are really here to talk about the African American Health Program, the Asian American Health Initiative, and Latino Health Initiative. Montgomery County is one of the most diverse counties in the nation. In fact, collectively, our Asian, Black, and Latino communities make up the majority of the county's population. So the term minority does not fully reflect the reality here in Montgomery County. In MoCo, no single racial or ethnic group makes up a majority. Instead, we have a truly multicultural community, and I'm going to go through some of the statistics of that today. These communities represent a significant, vibrant, and essential part of our county. And yet, despite their size, contributions, and diversity, many residents within these communities still experience being under-resourced, underrepresented, and facing persistent barriers to health and well-being. That reality is exactly why these programs and initiatives exist. They were created to ensure that the Department of Health and Human Services remains connected to the communities it serves and responsive to the inequities that still affect these health outcomes. Their role is especially important at this moment, at a time when efforts focused on diversity, equity, and inclusion are being challenged or scaled back in many places. The work of these programs reminds us that advancing health equity is not about politics. It's about making sure that every resident in Montgomery County has a fair opportunity to live a healthy life. Today, I will share how these initiatives work, the communities that they serve, and why their continued partnership with the county is essential to improving health and well-being for all residents. As is already mentioned, there are three programs. We have the Latino Health Initiative. Mariana Serrani serves as the manager for that, the African American Health Program, which is served by Juane Dixon, and our Asian American Health Initiative, which is served by Mohammed Hassan. The mission and vision collectively, and each of our presenters will go through their respective missions and visions, but collectively for the group, the mission is to advance health equity in Montgomery County by partnering with diverse communities, applying culturally responsive and data-driven strategies, and addressing systemic barriers to wellness. And our vision is a thriving, empowered, and healthy community in Montgomery County where all residents have equitable access to opportunities, resources, and conditions that support their overall well-being. Just a little brief background. Each of these programs, they sprung up in the late 90s, early 2000s. AAHP was launched in 1999 to address the disproportionate health inequities affecting African Americans. LHI followed just 1 year later in 2000, focusing on health, language, economic, and workforce barriers impacting Latino residents. And AAHI came to fruition in 2005, the first county program directed to the unique health needs of the Asian American communities. Each of these programs and initiatives sits within the Department of Health and Human Services. Each of them has an executive steering committee, which is an independent group of volunteers. And we'll go a little bit more into what those steering committees are comprised of. So collectively, the executive steering committees for these programs and initiatives serve as critical bridges between the Montgomery County community and the Department of Health and Human Services. They are comprised of community leaders, professionals, and advocates. These volunteers, and they are volunteers, unpaid, bodies provide strategic guidance, technical expertise, and community insight to ensure that each initiative remains responsive to the needs of the populations that it serves. They help shape priorities, inform program design, and promote data-informed approaches that advance prevention, wellness, and health equity. In addition, the committees play an important advocacy role in elevating community concerns and supporting efforts to secure the resources and partnerships needed to improve health outcomes. Through this collaborative relationship, the steering committees strengthen the connection between DHHS and the communities we serve, helping to ensure that the programs are community-informed, culturally responsive, and aligned with the county's broader commitment to health equity. They are quite literally the eyes and ears and hearts and hands in the community. Each one is unique and structured to meet the needs of their respective communities, and each one plays a vital role in ensuring that the work of DHHS remains grounded in community voice, guided by lived experience, and focused on advancing equitable health and well-being for the populations that they serve. Just to see where they sit within the Department of Health and Human Services, you will see at the top the director. Each of these programs and initiatives sits within the office of the director, with oversight from myself as Chief Health Officer and collaboration with the Chief Administrative Officer. You will also see at the bottom Public Health Services. The Black Physicians Healthcare Network sits within Public Health Services, with a dotted line over to AAHP. We will not be spending much time talking about BPHN today, as they are a separate service area and structured quite differently from these programs. I will just touch briefly on the budget. This is the FY26 approved budget. We will not be talking about the FY27 potential budget because it has not been finalized yet. As you can see, the African American Health Program in FY26 was appropriated $4.3 million, Asian American Health Initiative $3.7 million, and the Latino Health Initiative $6.2 million. BPHN was also appropriated $3.6 million, and again, that is administered through Public Health Services. I do want to talk just briefly about the changing county demographics. I think it's important to ground us in what the county looks like today and how that has changed quite significantly since 1990. In the last 36 years, we have seen the Black population increase by 58% from 12% to 19%. And you can see the areas of where that demographic shift has occurred within the county. We also see it's important to recognize that none of these communities is a monolith. And as we see diversity in the county overall, we also see diversity increasing within each of these racial and ethnic groups. And so for our Black and African American population, 56% of them are native-born Black, but then we also see about 36% from sub-Saharan Africa and about 8% from the Caribbean. For our, oh, sorry, I didn't advance that. Our Asian and Pacific Islander population has seen almost doubled, seen an 87% increase in that same time frame, and you can also see where those shifts have happened across the county. And you can also see the breakdown within that community. Similarly, for our Hispanic population, we've seen them triple over that same time period, and you can see across the county where that diversity lies. And the majority from Central America, about 20% from South American, that 55% North American Caribbean is incorrect, it should be 15%, and then other Hispanic Latino. Montgomery County also prides itself on our language diversity. 43% of residents in the county speak a language other than English at home, again stressing the importance of making sure that we are that our materials that go out are reflective and respective of the communities in which we are trying to reach. I will just bring up COVID as an example of the collaboration and importance that these groups brought to the county. We saw the success that we saw in vaccination was in large part due to work through and with our health initiatives and programs, especially around vaccination. This chart just shows vaccination inside and out of the county. The bottom pink lines, the darker shades, the dark red at the bottom are vaccines that happen within the county, and the lighter shades above it are vaccines that happened outside of the county. What we saw is once the county had vaccine in our hands, once we were able to have mass vaccination sites here, we were able to fully implement our vaccine equity framework and really saw significant improvements in being able to reach our diverse communities. When you look at the outcomes, our successes, our Black and African American residents were within 2 percentage points of non-Hispanic whites, near parity, essentially within standard deviation. Our Hispanic and Asian communities exceeded white non-Hispanic residents in terms of their vaccination rates. That was due in strong part to the work of each of our respective health programs and initiatives and the work that they did directly with communities. Each of them birthed collaborations in the community. Much has been said about La Abuelina and Por Nuestra Salud y Bienestar, not to mention their 4 Emmys and NACO Award. That really is a true resource in terms of connecting with community. Also, the African American Health Program quickly transitioned their programs like SMILE, which is for pregnant persons, diabetes prevention program, their community programs, to online in order to continue core services, implementing remote patient monitoring, again, to keep people connected to care and help decrease deaths. In addition, our Asian American Health Initiative provided community grants. We remember that during that time there was a lot of stigma and hate that was directed towards the Asian community. Around COVID, they helped with education and support, addressing mental health issues, and that did a lot of outreach to the business community. I think collectively what these groups did at a time when people were forced to be distant because of COVID, they continued to create a sense of community, education, and opportunity amongst our minority communities. With that, I will turn it over to Mariana Serrani, who will walk us through the Latino Health Initiative.
Thank you very much. Good afternoon. It's very good to see all of you. Do you want to pass the slides? You can. Great. Thank you. So, as Dr. David just said, my name is Mariana Serrani. I'm the Senior Manager for the Latino Health Initiative, and I would like to start with the specific mission of the LHI, that is to advance health equity and improve the quality of life for Latinos in Montgomery County by increasing access to services, building connections, developing cultural and linguistically responsive approaches, and remove the barriers in the system. With that, the LHI has 4 specific functions within Montgomery County. That is to enhance coordination between existing health and human services, provide technical assistance to programs and services among Latinos, develop and support models of programs and services that were culturally and linguistically adequate to reach Latinos, and advocate for policies and practices that are effective reach and service to Latinos. And that cannot be illustrated better than the work that we did with Salud y Bienestar during COVID. At the LHI, we have a very specific framework for our strategic management. On the macro level, we have the blueprint for Latino health in Montgomery County. This is our 10-year roadmap that it's about to expire this year, and it has 6 specific priority areas: to expand and refocus health and wellness, promotion efforts, equity, ensure equity access and utilization to quality health and social services, ensure meaningful Latino participation in decisions that affect the health and well-being of Latinos, ensure the availability of cultural and linguistically competent services, improve analysis, reporting, and utilization of health and other data for Latinos, and increase the number of bilingual and bicultural professionals in the county. These 6 priority transition or translate into the 6 core areas for the LHI. It's cross-programmatic integration, capacity building and onboarding, performance management and accountability, communications, contracts and partnership, and data evaluation. So our blueprint is set to expire at the end of this year. We are in the process of conducting a needs assessment, community conversations, and also in-depth interviews with key representatives of the community, and also visits the healthcare facilities to really understand that we are in track or if we need to adjust to what is to come. And accordingly, we might adjust our core service areas. When it comes to a few characteristics of the Latino communities, we are the 30% of the population of the state, and we are the 21% of the population of the county. About 220,000 residents are Latinos or identify as Latinos. When it comes to age, Latinos are younger. They are a decade younger than the average age of the population of the county at 30 years old versus 40. And Latinos tend to live in multi-generational households with a minimum of 4 people and up, when the average for the county is 3 people. So that's an advantage and also a disadvantage to live in such a household. So to highlight some of our health profiles. So Latinos had a main issue that is access to health care, and that translates in a lack of prevention services and continuous care. So they don't have a regular annual exam, they don't have a primary care, they receive late-term care for pregnancy, and many cases they can afford care. So this is also related to the social determinants of health. Latinos have a lower level of education, have live in poverty, have transportation issues, as we mentioned, lack of health insurance, the hour of operations of the healthcare system, and language barriers. In addition to that, health literacy is a big issue for the Latino community, that they cannot afford to access virtual appointments online. So how these lack of access and social determinants of health translate for the community? It translates of having a variety of chronic disease that can be preventable, like heart conditions, diabetes, asthma in children, obesity, and low birth pregnancy rate. Also, in the last few years since COVID, we've been actively working on mental health issues that have been, even though it's a taboo issue, they have raised in the community on anxiety and depression specifically. This is our wonderful team. The LHI has a multidisciplinary team of 16 merit staff, and we have a variety of competencies from public health, community outreach and education, curriculum and training and workforce development, to communications. And some of these areas are brand new areas to our portfolio that we're very proud of. Next, I would like to briefly go over our programs. So we start talking at the macro level that we have our blueprint and our core services for our strategic management. But when it comes to program design and implementation, we have guiding principles for our service delivery model. And the guiding principles are community-driven processes, focus on social determinants of health, eliminating health disparities, needs and evidence-based strategy, comprehensive and integrating framework, cultural and linguistically proficiency, strong collaborations and partnership, sufficient resources for success, and outcome-oriented planning. How does this translate in our planning and evaluation of our programs? Our programs are innovative and data-driven. We have consistently over the last 5 years received NECO Achievement Awards for our programs, the same as Emmy. We have 5 Emmys. We're very proud of that. Our programs are from children, with our asthma program starting with very young children in the family to older adults, 65 plus. We also provide services in person and virtually. We design our programs based on data for zip codes, where are the most needs of our community. Our programs are participatory and interactive. We facilitate navigation and access to care. We build capacity, and we work within our community. We work across our department and across the county. I really like this picture. I will go in more details in a different way to understand our programs. But the reason I like this picture because it depicts the variety of activities and the age groups that we serve. This is an image of our portfolio of 14 programs. So we can see children on the asthma, we can see La Abuelina, and we can see families that we're serving throughout the different programs. So this is another way to break down our programs. Our portfolio is divided in 5 service areas, and the service areas are outreach and engagement, workforce and training, awareness and education, health and human services, and communications. Our programs have grown a lot over the last year, so we have invested a lot of strategic planning in organizing ourselves in a way that is clear for the community and also serving the community. Under outreach and education, we have programs such as the community health workers that are in the community 7 days a week, providing education and attending events. We also have caminatas and healthy eating geared towards chronic disease prevention. We attend communities event, not only the health promoters, LHF staff does too, and we have our annual health fair called Ama Tu Vida. On the workforce training, we have the Welcome Back Center that trains internationally health care providers to transition into the workforce in Maryland, and we also have our certification training program. For awareness and education, we have an asthma for parents, for children that have asthma. We have climate and health that started as a little bit of an activity during COVID that has grown into a very comprehensive arm of our programmatic activities. We have family reunification, Latino youth wellness programs for youth, parents in actions for substance abuse and alcohol, and the golden years for older adults. And for health and human services, we are providing direct service into the community through case management services and our encuentros. There are community mental health groups, the same as the helpline that provide navigation services and referrals, and our interpretation services for Montgomery Care patients. And lastly, our communications. We have a website that receives over 1 million visits per year. We have an LHI Digital Connections that is a bilingual newsletter that has grown organically to 1,800 subscribers. So we also have 4 social media platforms that we are posting contents and reels every week. We have a very extensive strategic strategy for communications. And lastly, we have run a variety of digital and traditional campaigns, from television ads to digital ads. And lastly, I would like to just spend a little bit more time talking about our latest additions to our portfolio. And these programs have developed based on the needs of the community. The community has called us, have talked to the community health workers, and we are filling gaps that there are no other program with the same capacities within the county. As I was mentioned briefly, our climate and health, LHI has taken a thought leadership position. It started with Zumba, trying to connect with the community during COVID, and that has transitioned into a program that is multifaceted. We are featuring a Park of the Month, so the community learns about the resources available in the community. We offer Charlemos con Zumba in person and virtual. Throughout the year, we have 6 cohorts, and we have an average of 40-45 participants, and we are selecting different sites throughout the county, places that the LHI not necessarily has a footprint. And for example, when we're doing at the library, the people also get a library card. So there's always an added value, trying to go to places that we are not present and the Latino community would like services. We also do the rec centers, and they get a rec card. We have started forest bathing, that is a mindfulness exploration as part of the Charlemos con Zumba. Some other activities, we have these activities also in parks around the county. And lastly, we have developed a curricula for community health workers and also for the community to learn about the implications of climate and health. And all these efforts has garnished us an NACO award, an Emmy award for our grain of salt. And also LHI received a golden award for the inaugural County's Office Challenge. There is no printing in our office. For our 55 plus communities, one of our partners was telling us that they were receiving people once a month. People were like just showing up at their agency, and they didn't really have any programs for them. So we started a pilot, and the pilot grew from like 25, 30 participants, 55 and plus, their partners, their family that was dropping them off and waiting for them. And now we have bi-monthly, on average 43 participants an app, and it's a 2.5-hour workshop in which they receive a presentation. Sometimes on a health topic, sometimes it's an advanced directive, sometimes it's on digital literacy. They do an arts and craft, and they have a social time. And many times they are dancing. We have gone, and it's absolutely amazing. And they have like a social time. So this is something that fill a void into the community, and we're very happy that the community reached out and we were able to support that. For the Parents in Action, This program came about 2.5 years ago, and it started as a pilot when we were at the peak of the fentanyl crisis, and LHI was taking an active role in creating communications strategies for that. But we start hearing from the community that parents were saying, we are seeing all this information, but what is for us to do? So we engage the services of worldwide pharmacologists who help us develop a curricula in Spanish, and we start working with the small groups in high school of parents. And then we realized that it was too late, that by the time they get to high school, some of these children have already been exposed. So then the next cohort we did in middle schools, and it was already too late. So then we landed in elementary schools. There is no other program in the county that is working with cohorts of parents, of 15 parents, on a 7-session in Spanish with individual coaching sessions. And in addition to that, we are partnering with the Montgomery County Police Department to bring out the co-op trailers so they can look in real life to see what they might be looking in their children's rooms. And we also have created an alumni group because people want to stay connected to us through this program. So this is like another innovation that we have developed in the last 18 months or 20 months based on the needs of the community. And lastly, I know there was also a lot of interest in the Welcome Back Center. We have revamped the program. We have streamlined it, and I'm very proud to say that in June we're going to have the largest cohort of graduates. We're going to have 12 participants that are obtaining their RN and they're entering into the workforce in Maryland. Maybe more because some others are ready to take the test, but as of right now, 12 have completed the requirements. Thank you very much for your time. I'm happy to take questions later. Thank you.
Good afternoon. My name is Wina Dixon. I am the Program Manager for the African American Health Program, or AHP as I would refer to it throughout the presentation. I'm just going to advance here. So before I begin to describe the program, I wanted to start by bringing attention to the barriers and disparities that face the African American and Black community. And also want to clarify that for the African American and Black community, I'm referring to African Americans and those of African and Caribbean descent. Because we collectively, we serve all residents, and all these barriers are affecting all of the communities. And so there are 5 main disparities I think that we need to call attention to. And the first is economic stability. We know that there is disparity in incomes, although Montgomery County is a higher income county, and we have a number of pockets of extreme wealth. There's still some disparity between Black households and white households in terms of the income. And what that translates to is that some of our Black children are experiencing poverty at higher rates than the white children. We also have barriers to health care. Some of those barriers are not just physical access to clinics and hospitals, but it's the barrier to preventative and culturally responsive care. We know that receiving care from a doctor or clinician that looks like you and that also has like lived experience can also relate to you in a better way and can improve the way that patients engage and improve the way that they're open to talk about what they're experiencing or not, or what they're not experiencing, or if they have any questions. And also there's a higher reliance on emergency department visits for primary care. And that's primarily due because there's not as much connection to primary care doctors for Black residents. And so that is something that the Black Physicians Healthcare Network has been established to set up to create that connection. You know, as we do our screenings and identification, our primary role is to connect to care. Third, there is a very high chronic disease burden. And by chronic disease, we mean hypertension, diabetes, cardiovascular issues, high cholesterol. There is the highest heart disease mortality amongst all the groups, and this is due to a number of factors that's beyond race. This is environments in terms of access to food. This is nutrition, understanding what are good food choices to make versus what are not, and then also physical activity. And these are all things that we also try to address as well through our programming, which I'll walk through. And we know that there's a higher prevalence of hypertension, diabetes, and other related complications. Many of these occur because As I said before, there's not a primary care physician, so there's not active monitoring going on. Those two, they go hand in hand. But there's also the insurance. Not everyone has insurance, and for those, and especially right now, is there's a lot of uncertainty with unemployment and insurance. We're seeing higher incidence of people that don't have insurance. No insurance means they're not putting health first, which means that there's going to be a domino effect, not only in physical health, but also in the mental health, and we are seeing that. Fourth, there's maternal and infant health. Black women, they experience a low birth rate of 9.7%. Although this has been addressed and is improving in the county, we still have this is still lower than like the state average. So in that case, we are doing well, but this is still an issue that needs attention to be called to, and that, infant mortality is peaking at 12.2 deaths per thousand. This is also getting better in the county. We're lower than the state, but this is still an issue of concern. And this is also due to some of the things I already talked about. Chronic disease can impact a woman's experience while she's pregnant. Her access to health care can impact her experience while she's pregnant. Her access to nutrition and just information and support groups, all of these play into the kind of experience you have as a woman is pregnant and preparing for that part of her life. And lastly, there's the home ownership. There's 50% of blacks, when you compare blacks to white ownership, there's about a 50% difference. And so what this means is this determines the neighborhoods that ones are living in. This determines what the other things you have access to in terms of you're supporting your social determinants, whether it be childcare, transportation, outside, fresh air, walking. All of those things really play a difference, and they really make an impact in your daily life. In your daily life, of course, goes into your health care. And African American residents or black residents make up 19% of the county's population. So gotta do it twice. Okay. So I think I would say, because this is really what drives our mission and our goals. These disparities that we've identified, our overall mission is to eliminate health disparities and improve the number and quality of years of life for African American residents and people of African descent in the county. And what that means is we are looking at healthcare as a lifespan, starting from the youth all the way to our aging. We find that, or our hypothesis rather, is that if you start by addressing things early in life, that can impact your experience later on. We start with our youth, giving them education, giving them the tools, giving them the resources, all the way through to as boys becoming men and young ladies are becoming women. And as we know, as you become an adult and you make your own food choices, which may not always be healthy. But this is really what we mean by the qualities of year of life. We really want to look at the entire lifespan and look at it as one spectrum, not just pieces of what's happening. And through that, there are 4 major goals that we have to achieve our mission. It's 1, to raise awareness about health disparities in the community. There are certain things that we talk about. We talk about hypertension, we talk about diabetes. We don't talk about oral health and the connection to oral health and chronic disease. And so that is what we are doing, is educating people about the connections that they may not be aware of, and just raising those awareness about those disparities. We're also integrating African American health concerns into existing services and programs. This is our driving force. This is everything that we do. It's important for us to meet people where they are, not just physically, but just emotionally and even spiritually, to understand where are you in your healthcare journey. Do you understand health? Are you comfortable asking these questions? Do you need extra support? Do you need connection? This is how we integrate these concerns into everything that we do, because we really want to meet people where they are, not just physically in the community, but also where they are in their healthcare journey, to provide the support that that they need. Third, we're monitoring health status data for African Americans in the county. We do this constantly. Our program is data-driven. With everything that we do in the community, every interaction, data tells the story. Data tells us where we are and where we are not. And that is how we're responsive in our program, is when we identify those gaps, we intend to address those gaps, so that we can see, better outcomes and have up-to-date data. And lastly, we implement and evaluate strategies to achieve specific health objectives. This just means that we are very flexible. As the program is 27 years old, when the program started, population was smaller, and there was much smaller areas of concern. Now the population has grown, life is changing, technology is entered, life is happening, and so we are responsive to health needs that are changing. Our objectives are not static, but we are evaluating strategies over and over and over again to continue to be responsive and to continue to be effective and continue to be efficient in how we support the community to improve health outcomes. And lastly, as I said before, we serve all African American, African, and Caribbean residents. We don't have insurance or financial requirements or citizenship requirements. We serve everyone. Okay, and this is our team. So we are a mighty team of 4 merit staff plus 1 contractor and a broker rather who leads our aging. And our team is a clinical manager who oversees our clinical work. We also have our operations specialist who keeps our financial and admin things in order. We have a vacancy, and then we have 1 person that's focusing on our aging activities and events, and the PM2, which is me. I lead the team. But the majority of our outreach and education activities are led by our vendor. They are also a very big team. They're out in the community, very, very visible. Together, we work to support one another. We collaborate very closely, and we work together to implement our strategy. Good. So AHP, this is how we drive our impact in the county. We are really, I like to think of us as 3 cogs, and one of them is not more important than the other, but we work together to have an effective program. And so first is our community education and engagement. This is our visibility. This is our connection. This is us in the community engaging actively through churches, barbershops, the rec centers, senior communities, health fairs, wherever we are. Community is where we are. And so we are actively always engaging in community where we are welcome and where we see that there are gaps. And we're constantly educating through our resources, through our social media. We also have classes that are virtual and in person because, as I said, we want to meet you where we are, and we want to reach all of the community. Secondly, all of that education really leads into what I would consider to kind of be the heart of AHP, and that's our prevention programs and how we navigate. We are a prevention program. Everything we do is to prevent worse outcomes and to stop them where they are and to improve health outcomes. And so this is the heart of everything that we do. It's our prevention programs. It's how we navigate to care. It's how we address chronic disease. It's how we address through DPP, our diabetes prevention program, our weight management program, our remote patient monitoring program. We have so many different programs and services that we offer, and we also navigate people to care for long-lasting sustainability and support. And all of that leads to the most important thing here, which is improved health outcomes. Together with community engagement and education, combined with our programs and services, we will improve health outcomes. And this is how we reduce disparities and improve health outcomes overall. And we have about 6 or 7 priority health areas that we are known for. One of them being maternal and infant health, which is also known as the SMILE program. There's our chronic disease management and prevention, which affectionately I call CDMP, but within that there are a few other programs that I mentioned as well, which is our diabetes prevention, weight management, and remote patient monitoring. We have our cancer awareness and prevention. This is breast cancer, prostate cancer. We've gone beyond just awareness to actually connecting people to being screened. As we know, colon cancer over the past few years, the age for screening has come down, and so we want to make sure the community is aware of that. It used to be 55, now it's like 45, and so those are the kinds of things we want to talk about. We want to encourage women to get their mammogram yearly, and support them to access their mammogram. We also have our HIV and STI testing and prevention. We've actually moved beyond just testing for HIV. We were primarily screening a few years ago. Now we are talking about PrEP and connecting people to PrEP, and also moving that PrEP awareness from what used to just be men, but more to women too, so women understand that PrEP can also be effective for them as well. There's oral health. I talked a little bit about the connection between oral health and chronic disease. Many people don't know that there's a connection. We know go to the dentist every year, every 6 months, you're like, I don't really want to do that. But when you don't, there's an increase in and negative impacts on chronic disease. And so we really talk about like that connection, and we've done that by connecting with some of the dental schools and also the clinic that's in East County, supporting that pilot program, directing people there as well. And then there's mental health, which is integrated throughout all of our programs. We provide mental and behavioral health support throughout all. It's not just your physical health, it's your mental health. We have support groups, and some are individual and some are group, but just having that sort of, that support is very helpful. And then there's our aging and social support. This is where we are focusing on social isolation, dementia, Alzheimer's, physical movement, brain health. This is a growing population, and we're all heading in that direction. And so there's a number of things we're talking about now that can be done as part of prevention to improve like the aging experience, and to also support our aging population who are either aging at home in place or who may be in senior communities that could be isolated as well, but we still want them to feel connected. And lastly, there's sickle cell. Sickle cell is an extremely important issue in the Black community. It is, this is one area where we are growing our programming. We are not just talking about sickle cell, we're talking about the importance of understanding if you have the trait, because that can impact your fertility decisions. It can impact if you're an older adult and haven't been tested, it can also impact the younger generations who need to know these things and family history. So with sickle cell, this is a growing area for us, but is one that we've done some screenings and we've done some awareness, but we really are thinking strategically about what else can we do to support families in the county who already have sickle cell. How can they be supported in the long term? And so just very quickly, I wanted to talk about the connection between AHP and BPHN. We have very distinct roles. We are the outreach, education, and engagement piece. That is what we do. And BPHN, they are the clinical providers. If we think about how we work together, we identify high-risk individuals, and we are the ones that do the screenings, and then we connect them to care through BPHN, which is that culturally responsive care that I talked about before. And together with us working together, we achieve our health equity outcomes to support the county. AHP, as Dr. Davis mentioned earlier, we are in the director's office with a dotted line to her as well. And then BPHN is managed by Public Health Services, a completely different unit from us, but we do work very, very closely together. And so this is our framework and how we look at ourselves in public health. And this is really our 5 main areas. And there's really no starting point or end point. There's multiple entry points into AHP. The only question you have to ask yourself is, what do I need help in? So within this circle, you can enter anyway. Most people enter through our community outreach and engagement. That's our health fairs and our screenings that many people are aware of. Once we screen you and we identify something, we'll then direct you into our prevention and risk management, which could be one of our classes, or to a care person. And then we go to our clinical and care management. This is really, this is our more clinical services, more so for our SMILE program and the nurses that provide care for the SMILE program, and also for our chronic disease. And then there's also, we then point you to access to care and referrals. We make referrals within DHHS and outside to some of our community-based partners who are supporting the community directly. And then lastly, there's that community wellness and social connection. And so people can enter in any way through any of these, through directly referring themselves. It could be a referral we get from DHHS. But all together, our programs and our services, all of this together really improves our health outcomes, and this is how we support it. And on this next slide, I wanted to make the connection of where do each of our programs fall in this framework that I've just described. So within community outreach, this is where our community health workers are absolutely key and essential. They are out there doing the education, giving the resources, doing the screenings, making the connections. And then we also have our health classes and workshops. We have many, many health classes, virtual and in person during the week and on the weekends, talking about nutrition and physical movement, and even some latest topics in health, for instance, integrative health and complementary health. And then, there's our community partnerships. We really rely on our partnerships and our partners to support all the things that we're doing. Within prevention and risk management, This is where we have our screenings for CDMP for blood pressure and diabetes. This is our cancer screenings and our oral health. All of these things that we manage and we identify very early. What's not on here is like also fall risk management. When I talked about like our aging, we're also looking at that. We are looking at also adding there's a mental health piece as well, identifying, doing early identification to identify those who are at high risk. Our Smile Moms are constantly screened for social and health risk. And then there's our clinical and care management, which is our maternal health program for Smile. That's managed by nurses. All of our nurses are RNs, registered nurses. One of the registered nurses is a certified diabetes specialist, and she's also, sorry. Sorry, I'm going to wrap this up quickly, sorry. Yes, and so our chronic disease management, HIV testing, and diabetes, and then our access to care is additional social needs screening and our referrals to primary care, and then community wellness is our support groups. And all throughout, it's our data collection and reporting, which really keeps us abreast of everything that's going on. And then just very quickly, this is some of our successes in fiscal year 25. You can see the number of people that we've screened, our Smile clients that were served. We had a 6% average weight reduction and more than 3,000 community referrals. And I will end quickly just by sharing our vision for the future, where we want to go. It's expanding services to new communities. Where aren't we? Strengthening and diversifying our partnerships, continuing to improve our data collection, building on impacts and outcomes, and investing in capacity building, technical assistance, and technology tools. And I will end there. And thank you very much for your time. Thank you. And I will pass it to Mohammed Hassan to talk about AHI.
Hi, everyone. My name is Mohammed Hassan. I'm the program manager with the Asian American Health Initiative. The mission of the Asian American Health Initiative, the mission of the Asian American Health Initiative is to improve the health and wellness of Asian American communities by applying equity through community engagement and data-driven approaches. Our work is focused in 4 core priority areas: community engagement, community empowerment, capacity building, and change catalyst. All of the work we do, we try to measure the impact through 4 key outcomes: behavioral intent or change, increased knowledge, increased confidence, and enhanced access. The work we do is driven by 2 concepts: the model minority myth and through data. The model minority myth is the idea that Asian Americans are healthy, wealthy, educated, and acculturated. This false stereotype leads to 2 effects: an external effect where Asian Americans are seen as a monolith compared to the diverse group we are, and then internally Asian Americans internalize this and feel pressure to ascribe to the stereotype, which leads to which hinders the help-seeking behavior, and that leads to underutilization of services, which is sort of reflected by the data. When we look at the data, we see that a quarter of Asian Americans have limited English proficiency, which means they speak English less than very well. A third of them are the Asian Americans in the county are foreign-born. When you look at seniors, that language barrier is extended, that only 21.5% of Asian American seniors have Social Security income, whereas they represent 16% of the senior population in Montgomery County. When we look at just Asian Americans over the age of 55, they represent 32% of all Asian Americans. And then health insurance, we see that 26% rely on public health insurance, while 4.6 Asian American families live below the federal poverty levels. That number looks good. That's because it's aggregated data. When we talk about disaggregated data, when it is available, we see that Asian Americans, in this slide, you'll see they have 4% collectively are uninsured. But when you break it up and you look at disaggregated data, you see that the Thai community, the Burmese community, and the Indonesian community have very high uninsured rate. And this theme sort of spreads across the different disparities when we have disaggregated data. When we talk about diabetes, when we look at aggregated data, we see 40% of Asian Americans have a risk of diabetes. Disaggregated, 70% of Asian Indians have a risk of developing diabetes. Same thing with SNAP benefits. When we look at the aggregated rate, it's about 5.6% of Asian American households rely on SNAP. When you disaggregate that data, we'll see that 13% of Indonesians, Pakistanis, and Vietnamese rely on SNAP benefits. So what that means is we have to, because the Asian American community is so diverse, we have to have a diverse team. to help develop, customize the services for them. At full strength, the AHI team is composed of 13 professionals, a combination of merit and contractors working in 5 work areas. These work areas are community outreach, health education, capacity building, senior wellness initiative, and the behavioral health program. The way we design our programs is focused is twofold. One is focused on community residents, and the other is focused on community organizations. We focus on community organizations because we realize as government we can't be everywhere all the time, as well as the trust that community organizations have with their communities. We can't match that. The safe spaces they provide, we can't match that. So to help community organizations, we have sort of 2 work programs that are dedicated to improving their capacity. One is the Asian American Center of Excellence. The goal of the Asian American Center of Excellence is to support the Asian American serving organizations in developing and increasing their capacity to successfully provide health, wellness, and social support programs, social support service programs. Within ACE, there's different services we provide. Some of them are monetary services, some of them are technical services. There's the microgrants program, which is a funding opportunity for smaller organizations to acquire capacity building resources. There are strategy consults that we offer on demand to develop personalized plans for each organization based on the need they face. There's workshops that are aimed at building their technical skills, boot camps designed to give them hands-on training, roundtables to learn from the leaders on what are the challenges their community face, and networking opportunities for these community leaders and community organizations to collaborate to better serve the community. An example, a detailed example of the ACE services, the ACE microgrants, which is a funding opportunity that allows organizations to request funding to purchase equipment, hire consultants, and seek professional development. Per category, $5,000 is available. Per organization, $15,000 is available. The total funding pool is $101,000. And the idea behind the microgrants is really to help the smaller organizations build capacity. Our definition of smaller organizations are organizations with a budget of less than $1 million. The opportunity is currently open. Applications, or the deadline for the applications is tomorrow at 5 p.m. Another highlight of the ACE program are the ACE workshops. These are technical workshops that are aimed at providing organizations with the technical skills and best practices. In FY24 and 25, we really focused on data building, and in FY26, we focused on grant writing. The impact of, the combined impact of ACE is best illustrated by an example of an organization that attended the FY24 and 25 data workshops and realized they have a data gap. And what the data gap they saw was they're collecting data through paper forms and then translating those paper forms into electronic data, which was very time consuming. By attending our data workshops, they realized they can optimize their data collection through a CRM system. But to optimize that CRM system, they needed funding. So using our microgrants, they purchased barcode scanners. And those barcode scanners allowed them to issue their clients unique IDs with unique barcodes. And by scanning those barcodes, the CRM was able to identify the client to a specific program, the program to a source of funding. The source of funding would automatically build the metrics for each funding opportunity. Through this initiative, what it allowed their staff to do is focus more on analyzing the data and exploring future opportunities that can help build their organizations. One of those opportunities is the Healthy Communities Fund. The Healthy Communities Fund is intended for organizations to provide linguistically and culturally appropriate services in 3 service categories: health and social support services, behavioral health, and senior wellness. An organization can apply for more than one category, and $1.5 million if funding is available. For FY26, because of the work we were doing through ACE, we saw an increase of applicants. We had 37 applicants requesting over $4 million. Through a competitive process, we awarded 16 organizations. So that is sort of our capacity building initiative. Another part of our program work area is the community outreach. Through community outreach, we have multiple programs for the interest of time, I'll focus on just the Patient Navigator program, which is a program that is aimed to really assist those clients with limited English proficiency in accessing resources, getting information about them, getting on-demand interpretation services and case navigation services, where patient navigators go with them to appointments to apply for services. We also have the health education program. Through this, we develop materials in multiple languages on various topics based on the health disparity data we see and the feedback we receive through our survey forms. We also have a senior wellness program focused on the unique health and social needs of seniors. A signature program under the senior wellness program is the Friends Corner program. Sorry, I'm not forwarding the slides. The senior wellness program, the signature part of that is the Friends Corner. The Friends Corner is really aimed at providing services to Asian seniors, but at the same time building capacity of the organization. So the target audience for this are organizations that have a lot of seniors in their community, but they don't have a developed senior program. So we go out, we offer a series of workshops based on those senior needs, and then slowly help them build a senior program, and then we move out and they can provide those services on their own. We also have a behavioral health program. This is aimed at reducing the stigma of behavioral health in the AAPI community. We do that through various educational materials like photo novels, toolkits, workshops, offering mental health first aids, and also offering support groups. The impact of all those programs in FY25 showed that 98% of the clients we served exhibited a behavioral change, an increase in knowledge, an increase in confidence, and had enhanced access. A feature of the ACE program, 34 individuals from 10 organizations received professional development training, and the 12 organizations that received our on-demand strategy consults were able to, 9 of them were able to secure funding. In FY26, our priority remained to capacity building, through our funding opportunities, through our technical workshops, improving data collection through our grants program and program staff, offering technical assistance to organizations, providing mental health and services, hoping to reduce senior isolations, as well as providing disparities of education. All of our programs that are aimed at community residents and organizations help us realize that together we hope to accomplish building a healthy community. Thank you.
Well, thank you, everyone, for those comprehensive updates and overviews of programs. I know that every time we come together to meet with our culturally responsive health initiative programs and services to get these updates, data always comes up. And so I think in the next time that we meet, or as we're looking ahead, it would be helpful to know how we are evaluating our programs across the different data focused priorities. I know that the AAHI program gives a lot of money to smaller nonprofits, and it would be helpful to understand how you're evaluating these programs and services, what data points you're looking at, what goals you're setting prior to awarding these programs, and then how they are meeting those in line with the overall focus for this population. That would be helpful, I think, across all 3 program areas. I don't know if it was in the budget. I could have missed it, but can everyone share their remaining budget for the rest of the fiscal year?
Thank you. We are on target to spend all our budget for the money that is allocated to our RFPs award. We are at 50%, and for the remaining of the programs, we are expected to engage all the funds that have been allocated for the year.
So did you say you have already expended 50% and have 50% remaining?
50 or 60, 75. The invoices is a month or 6 weeks late.
Yes.
So, but we are on target to spend all our remaining funds.
Okay, all right. But you still have 60 to 70 remaining, or?
For the remaining of the fiscal year. Based on the invoicing that we have done, we have spent 50 to 60% with the remaining of the funds to be spent through June 30th.
Okay, all right, thank you.
For AHP, we have 41% of the budget remaining through our contract, and I don't have the number for the overall program. We are on track to spend all of our funding for the end of the year, but we have 41% remaining on our contract budget.
Thank you.
For HI, we've committed 90% of our funding through grants program and the upcoming solicitation for microgrants. We have also allocated most of the funding to other programs like our behavioral health initiatives and senior wellness. We have about 10% of funding left that we need to allocate for future programs.
Okay, thank you. As we're approaching the FY27 budget season, I know we're going to receive the county executive's recommended budget. Can you discuss your funding priorities for the upcoming year, any specific budget needs, and where you anticipate any increases or decreases to your budget needs relative to the upcoming fiscal year? I know that, there has been some impacts from the federal level, so I don't know if you've had to reallocate funding throughout this fiscal year to, support other initiatives that were unplanned or unforeseen circumstances. So if you can speak to any of that across the programs.
So I'll just speak overall, and then we can't really discuss the budget until it comes out. Next week, negotiations are still happening, so I don't know what where the final budget things will land. But I can say overall, the funding is what we put in will be consistent with what we've been able to do over the over previous years. So I don't expect big swings in funding. I expect things to be pretty consistent with how we have been previously funded.
Okay, but no issue areas where we would be asking for more increases because of programs or disparities across the programs?
Not at this time. We're continuing
Okay.
to work. I mean, each of the programs is specifically working on the disparities in this area,
Yes.
but there isn't necessarily a new COVID disparity that we are concentrating funding on.
Okay, thank you. And then okay, so I know that everyone is addressing the different programs and services a bit differently. Just wanted to see if you could highlight your initiative's greatest strengths and any areas for improvements. I know that you mentioned the Latino Health Initiative is having graduation with 12 RNs. Our AAHP program has some RNs already in the program, but just wanted to better understand what your greatest strengths are across each program areas.
I would say our greatest strength is our cultural linguistic competency. That continues to be an issue. I think our footprint in the community, we are working on being in half of the 80 zip codes that the county has, and we are consistently in the 40-45 zip codes areas of the county. We are about 850 to 900 events per year. So we are constantly trying to expand our footprint because Latinos are everywhere in the county. So our priority is to reach everyone where they are, and also continue to expand our network of community-based organizations. As Mohammed was saying, they are a trust in the community, and a team of 16 cannot be everywhere, but we need to be working with them, and we are engaging in capacity building and onboarding of smaller organizations. We don't have an outstanding grant programs that they do, but we do a lot of capacity building to bring in other partners, like for the Golden Years. We are working with a partner that has a strong foothold in older adults that we weren't working on. Yesterday, we met with someone that was working in domestic violence. So this is our priorities all the time, continue to expand and meet the new needs or needs that had been there for a long time and we haven't filled in the gap yet.
Oh, good. I would love to hear more about the specific partners that you're working with during our next check-in across
I would love
all
that.
program areas.
And there's one more thing that we're very interested on, that is digital literacy.
Oh, yeah.
A lot of our community members are unable to take part of all the great programs because they're unable to sign in, they're unable to use platforms to do that. So that's also a big interest of us. Thank you.
I think AHP's greatest strength is our community trust that we have. Over the years, we've developed a relationship within a lot of our historically Black communities. Very strong foothold, very strong presence. The community trusts us to come in and to provide advice and support and screenings, and they trust our advice on how to be healthy. I think our other strength is the diversity of the team and the various expertise that our team offers. Beyond the nurses, there's the social workers. There are the people that live in Montgomery County versus those that don't live in the county. We have health promotion specialists. We have myself, who I come from a social justice and health equity background, so I have that lens for healthcare. So I think the diversity in our team also lends to the creativity of the programs and services that we develop and how we deliver them. I think where I wouldn't necessarily call it area of improvement, but where we expand is we're also looking at technology. There are many people that we don't reach through our classes who are more technically savvy, who would want to have a connection through an app. There are a number of apps that we've been looking at. We've been doing mental health screenings via an app so that people can be more self-directed with their screenings, and if they can't connect with our social worker, there's a number of apps we've seen that are supporting mothers where they can connect in a community and kind of share the concerns, and the same, there's one we also discovered with sickle cell. And so what we're looking at is how to leverage and utilize technology in a way that fills in the gap of where we are beyond like the community-based services, and we've also started to print a lot of materials in French, Amharic, and Haitian Creole, and we've connected with some of the other advisory groups as well to help us get into those communities, to let them know that AHP is here and we are supportive and we are a partner.
Thank you.
Our strength is our two-pronged approach to how we approach the health and wellness of the counties. One is our outreach program aimed at community residents, raising their awareness and educating them. And the other part is our focus on our community organizations through our grants program. Both of them have a sort of feed off of each other. Through our outreach program and our behavioral health programs and our senior wellness program that are providing educational services, we're seeing that impact in our grant requests, where organizations are now more applying for more senior wellness services in those categories, as well as the behavioral health categories. With outreach, what we're seeing over the years is our Heritage Month event, which is our signature event, which combines the celebration of the Asian American heritage, a resource fair for them to learn about county and community resources, and a health fair for them to get clinical services and blood work. We're seeing those numbers increase to last year, we had 3,000 people attending that event versus 600 to 700 traditional attendance. So the two-pronged approach of educating and raising awareness to residents, as well as building community organizations, leading to a greater impact. Because as county employees, we're a team of 13 people. We can be as diverse as 13 people, but the Asian American community, looking at the ACS, is about 25 different ethnicities. So really investing in the community organizations helps us address, make the maximum impact into the community.
No, that's helpful. So I know that, these programs have been around for quite some time, and just wanted to better understand the disparities that you have seen improvements in, and if there are any trends across any programs directed towards those improvements. Your population has almost doubled, and so just wanting to better understand if there's any specific programs or services that we've seen the greatest improvements on. And given the growth, do you have the capacity to meet the needs of these increasingly diverse communities? You said that you are now serving, in addition to, American-born African Americans, but you're looking at the Black community across the diaspora. We know that the Latino population has grown, and so does everyone have the appropriate support staff to continue to address these needs, and are we seeing improvements in any specific disparity areas?
So it's interesting for the Latino community because we're also not a monolith.
Yeah.
We all speak Spanish, that's a plus. So, but we're all very different. I think that the different waves of migration have brought different communities. So in the last 5 years, we have seen an increase on Puerto Ricans and Venezuelans that they're young, they're technology savvy, and many of them are better equipped when it comes to language. And then we still have the families that they came in the 80s, that now they are in their 70s and they never learned English. So even though it seems like it's the same, we have very different needs throughout. So I think that's something that I wanted to highlight. We can always have more staff to be able to do more things and go to more places. Yes, to that. So absolutely. One program that has surprised us that is a very taboo topic is mental health. We have, during COVID, established Encuentros. We provided the seed funding for Identity to develop these programs, and these are groups. They were virtual. They study with women, and they have grown to men and to youth and in schools and in Spanish and in English. But at the very beginning, the Latino community is known to go to the therapist. That's a taboo. You don't have any problems, just move on. So people start feeling supported, and they start conducting research in alignment with the University of Maryland, and they have found that people that have support systems through Encuentros, their anxiety index, that when you are participating in this activity, can go from 0 to 6, go to maybe 1 or maybe 2 points. People were related or self-reporting at 6. So we know that mental health is an issue, and in the spectrum of mental health, some people need therapy, some people need inpatients, but there is a big part of the community that can benefit from having support, to having a place to talk about grief, to talk about the immigration experience, to talk about the loss. Like the community is being very affected by the current administration, and I think that's the reason these groups are so relevant, and we continue to see improvements in the community in an area that we weren't expecting with this anxiety scale.
Thank you.
Of course.
I know that, emergency room usage by the Black community was mentioned, and so with the establishment of the Black Physicians Health Network, can you speak to any mental health improvements or any better connections with healthcare providers or anything else that you've seen?
So specifically for the connection to the Black Physicians Health Network, they have, as their network has increased, that has given more access to the care connections that we can make. They've been adding on primary care physicians and mental health practitioners as well. And so that has improved our referral process between the two of us. So, for example, before there used to be sort of a wait list, if you will, or we had to, maybe look for another partner. But those incidences have decreased because they've increased their network. But we've also looked outside of BPHN to expand the network as well for care providers. There are smaller private mental health practitioners that also serve the Black community, so we've also been connecting with them as well as an alternative, because I think it's important for us to diversify who we're working with, and so that we're not just going in one direction, because there are a number of practitioners in the county that are supporting. So we've seen that, and we also have some additional consultants who are providing mental health services through support groups, individually or group. Beyond that, our greatest areas of success, I would say, is our outside of the diabetes prevention program, we have the Gold Star designation from CDC, which indicates we've had it for a number of years. That's just indicative of our standards of putting the cohorts that we manage, the data that we provide, and the successes that they're seeing. So we're really proud of that Gold Star designation. In our weight management prevention program, there's been a significant amount of weight loss and a significant increase in movement. I think the most recent story I heard was someone's moving like 600 minutes a week, and I'm like, I need to start moving. So there's been a real significant amount of weight loss and movement, and I think it's because the way the program is designed, it is more collaborative and supportive between the cohort, and they're all encouraging one another, and it's like, oh, that person's losing, so I want to lose. And so we're really seeing a lot of results with that. And then with the SMILE program, we are very well connected with like Babies Born Healthy and MCH, and collectively we refer to one another, and we're also looking at ways to continue to support moms. But the results that we've seen are, majority of our babies, we've seen a reduction in low birth weight. I think we're more than 90-95% of non-low birth weight. We've seen 85% in breastfeeding after 3 months. We still have like a retention after 12 months. That's how long we keep the SMILE moms, after 12 months. And I think what's really changed in the program is the involvement of fathers. That's a new component that we've added to the SMILE program, is involving fathers in the process, as the parenting process, in the 12 months after the baby's delivered. So that's an area that we're also seeing improvements in.
Thank you.
Because of the limited data that is available, it's hard to measure impact on a disaggregated scale. But on an aggregated scale, we are seeing slight decreases, and we're talking about like 1% or 0.5% decreases in senior disability amongst Asian Americans, or the rate of Asian Americans that are insured is slightly increasing. The limited English proficiency is getting better, but outside of that, if we're looking at anecdotal data through our outreach program, the success of that, what we're seeing is we're seeing increasing presence of Asian Americans at food resource hubs, where they're trying to get access to services. We're continuing to do needs assessment on that. And then through our behavioral health and educational programs, we continue to see our our organizations requesting and delivering more services to seniors than previous years, and in behavioral health than previous years.
Okay. I need more information. You're about to open up an application that's giving out over 1.5 million, you said, and you aren't able to share what data you're tracking or evaluating this money for. That's important for us to know, and for you to understand who you're serving and what outcomes you're aiming for. So it would be helpful to have that information across all of our program areas. You want to share something, Dr. Davis? And then
Sure, two things I want to just highlight. So one, I want to commend each of our programs for the work they've done in mental health in each of their respective communities. Each of these communities has seen mental health stigma and they have each helped to break down those barriers. And as a result, I think we see more people in those areas coming forward with mental health issues. And so as a result, I think we've actually seen increases in mental health challenges, but I think that's a fact of awareness. And people are talking about it in a way that they haven't. The other thing that I will just speak to is each of these programs is really good at impacting change in the people that they touch. When you talk about SMILE, when you talk about community health workers, when you talk about the micro grants, the people that they touch, we see improvements in, and we recognize that that is a very small drop in the bucket when you compare it to the 1 million residents that we have in Montgomery County overall. And so if you were to look at just the program, how many people are improved by participation in the diabetes prevention program, each one who participates, we have really high success rates. And does that move the needle on diabetes in the county? Not really. And so when we think about these programs and the potential impact for them, our ability to outreach more, reach more people, have a broader scope, that I think is the rate limiting factor in being able to have a bigger impact in a way that moves the needle on a graph for 1 million people. And so I think the corollary to the question of budget and kind of what do you need to be successful is really an investment in that infrastructure. And so it's great to have, one-time funding for a program, but that doesn't allow us to build in a way that's sustainable. And so, I think all of these programs would benefit from being able to give out grant funds and doing all those things, but to be able to have the infrastructure to do the metrics, to do it right, means, really investing in the programs in an even bigger way, I think, than we have.
Yes, thank goodness we're in budget season, so hopefully that's being communicated to the county executive of the needs to ensure we're seeing success across the growing demographics as the majority community demographic is present here and experiencing the most disparities. So I'll turn it over to Councilmember Friedson.
Thank you very much. I'm going to build on that. First, let me just say thank you for all the great work. Thank you for the great presentations. This is really one of the ways in which Montgomery County has really distinguished itself. And during COVID, when we talk about what we did differently, I will say I think a large part of our performance during COVID and the health metrics during COVID were less a function of county government and more a function of county residents who really got it, who believed in public health and in science and did what they were being told to do. And I think we need to give the real credit where it's due. It was less about us and more about them, and I think we need to lift that up a lot. But I do think the one area in which county government, which was anywhere but perfect in many ways, and I raised some concerns throughout that process and a number of ways in which we handled our work, which was very challenging at the time, but it was the fact that we had these initiatives set up and that we were able to dig deep into the community. I think we could have done it earlier and more intentionally and more specifically and tapped into the Office of Community Partnerships, which is something that I had suggested, of shifting the census efforts, which were intended to reach the very same challenging to reach communities in culturally competent and language appropriate ways. And ultimately, though, we did that. And then you look at the numbers reflected that. Unlike in most other places, it was our communities of color that outperformed in terms of vaccinations and in terms of rates of transmission, et cetera, all of the key data. It was these communities that outperformed our white population. And that is despite all of the health disparities that exist, and that is a function of the fact that we're meeting them on their turf in their terms in ways that made sense to them. And I really do think that these initiatives were the key to making that possible, and it was the infrastructure that was already set up and the partnerships that were already established that allowed that to happen. The Bienestar y Salud initiative doesn't happen unless we already have a Latino health initiative. If we didn't, and we're starting from scratch and we were creating those partnerships, that never would have happened. It would have taken 3 years, and by 3 years, we would have lost people before we had a chance to meet them, to see them, to serve them. So just want to acknowledge that, lift that up. Having said that, I do want to just build on the data piece. I do think we need to take this effort to the next level of disaggregated data and really think through what that looks like. And I do think that having one set of data for all of the initiatives is probably not the best way to approach it. The whole benefit of this is that we are targeting our interventions and our programs to communities in a way that makes sense. And different communities have different challenges and different needs. So I think there are some things that are across the board. Mental health, as you noted and lifted up, that should be an across the board one, because that really impacts each demographic group across the board in very similar ways. It might manifest in different ways, but the data probably shows up in different ways and can be looked at in different ways. But there are certain things in terms of sickle cell and diabetes and HIV, and there are certain programs that are targeted to specific communities for a reason. There's a reason why this isn't a broad-based single initiative. This is individually targeted initiatives to different communities, which are in and of themselves pretty diverse in their own right, as you noted earlier. So I would love to see disaggregated metrics, not just data, but metrics, to say this is how we are judging, this is how we are evaluating each of these programs specifically and each of these initiatives broadly, to say how are we doing. And I would suggest that it be, we'd have the across the board, the mental health and certain things, and then the specific to each initiative, based on what the initiatives are focused on, based on the assessed and determined community needs. You're serving different populations that have different requirements, different needs, different challenges, and the metric should reflect that. And also looking at the difference between county-wide numbers. A lot of the data that we were talking about here are county-wide numbers. How are we impacting fetal infant mortality? How are we impacting birth rates, birth weight, these types of data sets? That's helpful to say how are we doing countywide. I think it's also important to figure out what's the data that you're looking at that is programmatic based, of exactly what you're looking to do, and what are we seeing based on the populations that you're serving. What are the outcomes for those populations? And thinking through what's reasonable and not reasonable in terms of how you can do that. I think there are limitations, particularly in the current environment, of who is willing to share information, who are we asking to share information, whether or not the sharing of information is scaring people away from being served in this current environment. I wish that weren't such a challenge, but it is. And figuring out that balance. But I think that would be helpful for us to all be on the same page. And then, if not ready for this budget year, for future budget years, being able to say, here's what we did, here's how it worked, here's where it didn't work, and then that becomes the justification for making changes. Because the challenge we have right now is, I think that the interest in making changes are justified, but they're not accountable in a way that I think is helpful, where they can be communicated at the outset. Everybody knows what they are, everybody agrees to them. That makes it fair to the partners, that makes it fair to the department, that makes it fair to the council and to the public, the taxpayers who are actually paying the bill for this stuff. So that would be my strong urge. I don't have the answer to exactly what that should look like, and I don't think really the council should. I think this really needs to be work that the department does, working with subject matter experts, also working with the partners to determine what is fair. The performance evaluation, you meet with the team member and you say, here's what we're going to judge you on. We all agree on that. A year from now, 6 months from now, every quarter, whatever the case may be, there's no surprise when you come in to have this meeting of exactly what this conversation is going to look like. And then we'll talk about it. And to me, that I would love for us to get to that point. So I would just love your general thoughts on that, of whether or not we think that's doable and what that might look like moving forward.
I would say, I think collectively that is the goal that we are driving towards for all of the programs. I think we are working together collectively in a way that we haven't before, and have hopefully access to data in a way collectively that we haven't before, which gives us, again, as we build the infrastructure to be able to do those things, to be able to look and say, not just what is your individual program doing. One of the things that I would like to do now, having a closer connection of these programs to the health officer, is to say, okay, here's the data of what we're seeing in the county. How are we collectively strategizing to meet the needs and address the disparities? Which isn't quite how we've done it. Each team kind of takes their piece of it and runs with it. But having more of an overarching, here's the disparity, how are we each going to get there together, and collectively and individually, I think is what we're looking to do as we kind of go into the new structure and where they're situated in the department, which gives us, again, more access to data and epidemiologists that they haven't had as much before. So I think it allows us the ability to say collectively, okay, here's how we're setting the goals, here's how we're meeting for example, the diabetes goal impacts all of our communities, how we address it is different. And so thinking, how are we working towards these goals? What are the programs that we are doing in each of these programs to meet the health need, and how do we do that collectively and also being individually reflective of our communities?
I appreciate it. I would just really urge thinking very specifically of countywide versus programmatic, and thinking through across the board with all the initiative versus the individual initiatives and what their focus is. We can circle back on it. I know we're limited on time, but that would be my strong urge, and I just want to appreciate again all the work that you all are doing.
I'll just say to that, the other part of that is County Montgomery, which is our local health improvement coalition that looks at the health of the county as a whole. How are we improving health outcomes, which each of them have a seat on Healthy Montgomery. So again, that is working towards the health collectively of the county, and then also how are we meeting those goals in our respective communities.
Yeah, I appreciate that. Councilmember Friedson didn't join us at the Community Health Improvement Plan kickoff that we did back in January, where all of our organizations' initiatives came together and talked about the data that they would be sharing. And so in addition to behavioral health, oral health, there are some areas that we can agree upon where we can have some synergy on how we're evaluating and collecting data in a more collaborative way. I don't know how often these three groups or entities are meeting and exchanging information, but it would be helpful to better understand, how we are evaluating the resources going out and the return on that investment.
Yeah, and just to clarify, I agree, and I appreciate that the data is starting to be collected in more significant ways. I appreciate the work that you're doing in order to do that. There is a difference between data collection and performance evaluation. And what I'm trying to suggest is, rather than saying we're collecting data, then after the data we're going to summarize it and tell you what happened and what it looks like, what I'm saying is at the outset, we agree, here are the performance metrics that we are evaluating. Here are the things that we would like to see or we would expect to see at a certain point. You can't do that unless you're collecting the data, but I don't think just collecting the data is enough, because it doesn't really mean anything from a budgetary standpoint, from a focus standpoint, from a prioritization standpoint, where we can understand what's working, what's not working, where we should be investing our dollars, where we should be moving our dollars, and how do we move forward to move the needle. Because ultimately you may be getting too much credit or too much blame for those data, frankly. And I think we need to target it and pinpoint it. And I do think thinking through so that you control for macro trends like mental health, you could be making huge inroads, but the actual numbers could be going up. So compare that, say we're going to compare it to the national numbers, for instance, to say what are the county disparity versus the national disparity, or if health disparities are increasing nationally but ours are increasing at a lower rate, then the intervention could be working. So that's where you need to do a little bit of nuanced work to understand not just the data but the metrics and the performance evaluation to say, okay, how are we going to evaluate what it means to make an impact in these key areas that we're focusing on. And then I think you need to pick specific ones that you think are the most important, And that's really where we need to be pushing. Thank you.
Thank you. So I'm going to take over where Councilmember Friedson just left off. And, you know, a lot of times at council we talk about data in this way that makes it seem like there's some mass computing place that data just gets cranked out of and given to us whenever we ask for it. And I know that's not the case. I also know that data sometimes will get a set of data and it'll say, you know, X number of this, Y number of this. And that's a very simplistic way of trying to evaluate success. And it doesn't really measure the true outcome of a service or a project or a treatment, if you will. That's very basic, right? And that takes away from like the people part of things. The people part's pretty darn important when you're talking about the services provided by these programs. And so it occurred to me that especially when you're talking about data evaluation and metrical success or lack of success or lack of moving the needle. I don't want to call it not successful. It just might be harder to move that boulder up the mountain sometimes. Okay. That's much more nuanced and complex when you're talking about programs that are adapting services to meet ever-changing needs within the particular populations that you serve. And so, you know, I trust that based on the individual needs of each program, and through your leadership, Dr. Davis, that you would be able to come up with sort of the spectrum of here are the things we're going to look at. These are the ways we're going to track and evaluate. And you're right, it's not just collecting data and then going back and doing it, because then you might not have the right pieces for it, right? And then you don't get the right things you need to determine how to make your adjustments or add more of or come to us and explain. But that I think that is significant in terms of setting scope and everything. You all know best how and why to set the scope in the way that it is based on your individual programs. One of the things that did occur to me of something you may want to look at, although I may be preaching to the choir, is that because these programs serve broad spectrum of ages, there may be program participants where there's one or more member of a household participating in the different programs. And I think that is important to assess, whether it's siblings or a parent and guardian and a child, or child and grandparent, however it may be. But understanding sort of the kinship relationship of program participants and how that collective participation across one or more of a program's offerings may affect the overall success or outcome for those types of things would be useful. I wanted to just touch on a couple of the things you said and the updates that you were giving. I thank you for your asthma management program. That has been a challenging chronic medical issue across, my entire lifetime, and I have asthma, so I'm, not ashamed to say that. But wondering how what you're doing with the asthma initiative ties in also to the climate and health initiative. So could you speak to sort of the intersectionality of that?
Of course, thank you so much. Actually, right now we're running 3 cohorts, and in addition to the sessions on the curricula for the asthma program, we are adding a home assessment to understand what the triggers in the homes are.
Right.
That comes with a toolkit for clean products, like vinegar and baking soda, how to use them,
Right.
with a newsletter. And we're offering individual coaching for the parents to, go to their home and really see how they're using the medication, how they understand the emergency asthma plan. My daughter has asthma, so I'm very familiar. She had been to the training.
Got a whole house full of us. Yeah.
when the time goes going on. So, and the asthma program is linked to the climate and health. participants from the asthma program take part on the forest bathing, and sometimes they participate on the Zumbas. And these activities, they're not just the Zumba. There is a presentation ahead of time with different partners, and we talked about the links to mental health, the links to clean living, and using products that are good for the environment and have health impacts.
And I want to thank you just now for raising how to use the baking soda, how to use the vinegar, how to use things that aren't necessarily harsh chemicals, but that are like everyday, regular pantry staples that can be used to effectively clean and or solve an issue in your household without introducing other irritants. Yeah.
Correct. And also we do check for mold. That's the reason we go to the home and we do the assessment and then give the participants the tool to deal with their landlords many times.
Right.
How to clean the pillows, how to clean the stuffed animals, because we're dealing with children.
Yes.
So those are all added values that the curriculum of the program has grown into these other elements that fortify its impact.
And I want to thank you for highlighting the alcohol and substance use awareness issues and starting with parents of elementary school aged children, and why that's critically important, because, I don't think people often, if you don't have a child already who's hit middle school, you may not be aware of the level of usage of certain substances that starts. Some of it has started before middle school, but the bathroom environment at the middle schools tends to be a place where people start to learn more that that's happening on a more frequent basis. And even, and I know some of the kids that are in the middle schools who are engaging in that, in using vape and other items, and they're athletes, and they're hoping to go on to being a high school athlete, and they're already doing damage. So, that's incredibly important to make sure parents have eyes wide open and knowledge going in of what to even look for in the home.
Absolutely. And also there is a very subtle, non-spoken piece of the Latino culture that is drinking very young. As young, give them a little bit of wine with soda. And this is like the beginning of the behavior. So also, even though when you're not talking to the parents, maybe your child at this point is not engaging in using drugs, you are opening the path by starting with the alcohol. Right. So that's the reason the alcohol is such a big piece on the education towards drugs. And, how are the parents behaving at home? Right. And we started working with FCPS, and now community-based organization and faith-based organization are reaching out to us because they want to have groups on their own sites. So that's also talking about the impacts. So thank you.
Yep. And I know that this is an issue that affects all of the programs, but certainly for individuals who are now not engaging with the services that you are offering, who could otherwise benefit from and engage with due to immigration fears and worries, that, increases. The no insurance piece is one piece of it, right? It's always been a big piece, and it's always been a significant barrier that keeps EMS calls high and ER visits high. But now we have an extra layer on top of that will in fact increase, again, more EMS calls, more severe impacts, and more ER visits, or not calling for help at all. And so I wanted to know if each of you could speak to what you may be doing to try, because again, if you're able through your teams to get that word out into the communities that are being served so that they can then share that with others who haven't interacted directly with you, of what best to do, how to do it, how to make sure they understand that you really can come to the ER. If you call fire and rescue, that is all who's coming. Fire and rescue will come. They will take you to the hospital if there is an emergency. So could you speak to how you may be adapting your messaging or talking about that with your communities that you serve?
Sure. So the County Council, PIO, produced a series of videos about the police, so we really did a lot of promotion of the videos. the County Council PIO for the Latino community is a great ally of us. We go to their program all the time and we get the information from them and to them. So we have been partnered with them and get the information out. In the past, we have done interviews with Kathy Estrada, Captain Estrada, because, you know, she speaks Spanish and she's very well known in the community. So that message is one part. Since the beginning of this administration last year, we were working with our case management provider, that is Identity, and we developed a family emergency plan.
Right.
That for a long time there was no uptick. People were not interested. People did not understand why they needed to complete it, along with the standby guardianship. So we did a communication campaign. We use our community health workers to refer participants, and slowly but surely, people start taking part of it to try to prepare themselves for what is to come if the situation ever faces their family.
Right.
Along with referring participants either to the LHI or participants in the community to legal clinics.
Okay.
So all this is not promoted on social media. We are going above and beyond. So it's all word of mouth. It's
And
the
person to
community health workers. It's in the community and at events.
Right.
We have also, when it comes to our events, we were preparing to transition to virtual last year, but that didn't happen. People continue to come to our events. So we go the extra steps of, we don't promote any address.
Right.
So you come to our online, you register, and then there's no group chats. We individually call each person, and a day or two before the event is when we first release the address, because we don't want people to know where the Latino community is going to be congregating. So we're taking all these extra steps to try to provide information in a safe manner that they know that they can come, and also to continue to engage with them in person. Related but separate, our food post, we put the food post at the beginning of the week, and every day all the distribution sites continues to be our highest engagement post for the last 3 or 4 years.
Yeah.
And we put all the details because each center is different, so people can attend to them and see what works for their family. And we get a lot of emails, through our social media and to provide resources, and that's how we do it.
Great, thank you. And then the other two members would like to speak to that.
Just very quickly, most of our foreign-born moms are in our SMILE program, and the SMILE program is a home visiting program.
Right.
And because of worries, we've seen a reduction in home visits and a willingness to participate and open the door. And even because now there's another layer of decision-making in the home. It used to just be the moms would say, yes, we want to engage, but if the husband is like, no, so we're having to deal with that added layer of decision-making. So what's happened is we've got less home visits and more telephone visits.
Okay.
And that's even changed to more SMS, the communication.
okay, yep.
The communication has become a bit more difficult, but what we've communicated to the moms is that we are not sharing your information, and we're also just reminding them to please continue with your checkups and your care and let them know that we're here. And we have an outreach navigator who's specific in one of the communities, and she's reaching out, and we're also partnering with the Office of Community Partnerships to let them know that we're still here, because we have seen that reduction, and this has really only been in the past few months, so we're still finalizing our best way to communicate and making sure the moms are supported and seeking the care that they need.
Great, thank you. And for the Asian American Initiative?
So we do it in sort of 3 ways. One is direct outreach through our community health worker program, our patient navigator program, and our small business outreach, where they promote the resources that were published by the Gilchrist Immigration Center, the Know Your Rights platform. So we promote it that way. We also share that information with our steering committee organizations that then share it with their community, and the third level is through our grantees, sharing the information that is being published by the Gilchrist Immigration Center and the other similar organizations.
Great, thank you.
Thank you to my colleagues, and thank you to all of our health initiatives for all of the great work you all are doing. We all look forward to seeing what the county executive recommends in the next week now. for next fiscal year, but we cannot do this work alone, and so we appreciate the partnership. We appreciate your ongoing efforts to expand your reach across our increasingly growing diverse community, and so just thank you for the work you're doing, and we look forward to a fruitful budget season coming up. Thank you. We are adjourned.